Okay. All right, so I'll be demonstrating, get down so you can see me. I'll be demonstrating some thoracic and cervical techniques today. We're gonna start with the supine thoracic manipulation or the pistol manipulation. So for this one, you really are looking to match the level of the thoracic spine that we're at. So I'll start with just right in the middle where it's easiest, where we've got a good bit of kyphosis, so I don't have to do a lot of fancy stuff. So we'll start laying on their back. I like to keep their knees bent because I think it helps me promote more flexion up top rather than extended with their knees flat against the table. So then I'll have you hug yourself. Yep, and we're really looking for no arm crosses, elbow over elbow if you can get there, and having them hold there. Obviously, I would ask if he's ever had any shoulder issues in the past. I would change the way that I'm doing this to be either single arm or I might have to use a pillow or something else as a prop. So once we're here, if I'm targeting his left, I'm gonna stand on the opposite side and reach across. People like to do pistol. I usually just use my fist this way. It feels more comfortable for me. Palpating the spine. At this point, I would have already found the segment that I wanted to go for, maybe marked it. Here, roll him back over right on top here. If you want to get an even better grip, you can pronate or ulnarly deviate there and really get on that level. And we're gonna come right up over that segment, press straight down. I already just did this to him, so I'm not gonna press too hard, but we're really looking for a force to match the level where your hand is straight through the patient's humerus, and that force is applied through the chest so that you can get a good amount of enough force through there to get a cavitation. So if we want to adjust this to go higher or lower on the thoracic spine, a lot of times if I want to go higher on a patient that outsizes me, especially, I usually use a pillow to help get more flexion at the upper thoracic spine by propping their head up, as long as they can tolerate it. Let me slide down just a little. Okay. And then I'm going to change his grip here and really try to pull the elbows in. Great. And roll in here. He has really tight lats, so come here. So really just going upper thoracic, wherever you might find that on them. For him, he's got a lot of stiffness here. Okay, again here, and then really having to change on him. But this isn't my best with this table. I would want to get him on a high-low table and lower down so that I can actually get my chest over him. Another way that I'll do it in the clinic if the patient really outsizes me is using a half foam roll, like cut in half width-wise, or like a Colton board wedge or something like that. I've only used those foam rollers if they really, really outsize me, but a wedge can help as well to help target that segment. You can come in over the top and apply the force there. And then come back to this grip here. And I'll really have you push down that way. Okay, coming down lower here on the lower thoracic spine. So he's got more extension back here, so I find these to be more difficult to get in the clinic. Here, and really having to go again through the humerus if we can. So I might even try to get a hold a little bit lower. Yeah. Same thing across, quick down there. With that one too, another way that if we need a little bit more flexion, I don't think I know if I explained super well in the first one. When I'm coming up here, I'm really scooping them to try to get a better angle to match the level of the spine. You can do the same here. I've seen a lot of clinicians that will have the patient bridge to get that. I personally don't love that one because I feel like the patient's guard a little bit more. So I might prop their legs up on a stool if I really think I need to get a segment down there, or I'll just change the amount of scoop or just use a wedge. Okay, so Cleveland et al. It says that after a pistol thoracic manipulation, actually they found that lower trapezius strength improves. So worth considering. I like to use this for patients with thoracic pain, stiffness. Again, the cervical clinical practice guidelines tell us that for patients that are grouped into that neck pain with mobility deficits bucket, any of the thoracic manipulations are indicated. So while we still have him in supine, I will do quick, so I'm moving kind of slow. First rib mobilization. So to get the scalenes on slack for this, if we're really going for first rib and not a scalene stretch, I'm gonna bring his head, side bend it towards the side that I'm going for, and then rotate away so that those scalenes will settle down and I can actually get an inferior mobilization. I'm going to come straight down from the articular pillars onto that first rib. Actually, in a good spot. And with my inferior mobilization, I'm going towards the opposite ASIS is the direction of mob there. And then assessing for symptoms here. I like to use this for thoracic outlet, any kind of radicular symptoms. Anything where they say that breathing might be a problem as well. And we can do that mobilization in supine, seated, or in prone. I will also show the prone because I think a different group has seated. So go ahead and turn on your stomach. And all of these that I'm showing, stay here, are also in the Cook and Maitland texts as well. So if they can tolerate having their head a little bit off to the side, how his is, it's just a little bit in the face hole there. Again, rotated away, I can side bend towards the side that I'm going for. I'm also having a little bit of extension here, so it just depends on if they can tolerate this. But I like it because I like palpating the first rib posteriorly. And again, our mobilization is towards the opposite hip, and I'm mobilizing with my MCP. And I would, in the clinic, probably come and use my body to get a better move on this one. A high-low table would be nice. We can't always win. And while he's already in this position, I'm gonna do the CT junction manip in prone. Really good for cervical rotation deficits or just cervical mobility deficits in general. So if he's facing towards his left like this, I'll be targeting the right. I do like to have their hand in this position here, and I usually tell them, see if you can look up towards your thumb with your whole head. And he's in the hole a little bit, so scoot this way. That has gotten me in the clinic more than one time. For this one, okay, I'm gonna come and palpate C7. And when on a neck his size, I really can't use my thumb. I'm not strong enough, so I have to do this with my MCP on a smaller patient. I would come in with my thumb to block here for this manipulation, but I like it better on my MCP so that I can really get deep towards that. The deepest part of the spinous process that I can get to really give me a good block. And a lot of times, I'm sure you guys know this, but we'll get a manipulation just on the preposition. So he is extended, side bent, and rotated. I'm gonna have this hand on the zygomatic arch here, and all we're doing is applying a just a quick stretch into extension side bending. So coming here, and I like to have my hands in more of that opposite shear. Very quick. This is his favorite for me to do at home. And I usually do like to do this one bilaterally when I do it. I've just found that also if I don't get it on the first side, if I go to the other and then come back, I can usually get it for whatever reason, I'm not sure. But that's usually what I do in the clinic. So let's see. Okay, now put your head down flat and just kind of center up. And I can't remember, I can list it. But it's another one of the Cleveland articles. I don't know how to pronounce his name, it's kind of Italian, like Mazzaraccio, but it's on our thoracic reading. But he, or they, in their research article showed that cervical and thoracic manipulations in general resulted in decreased pain, improved NDI scores, and improved global rating of change for neck pain. Again, when I was looking at some of the evidence, there was not a ton of evidence on thoracic manipulations for thoracic pain in general, but for adjacent regions, it was very good for cervical and shoulder especially, as well as some for lumbar spine. We know that improved shoulder pain and function can come from thoracic mobilization and manipulation. That's a bunch of articles, Hake, Muth, and another one, Cadoni, that all show improved shoulder pain and mobility or function with thoracic mobilization. So we're gonna quickly show thoracic CPA and UPA. I think Morgan, I know, did this one on the exam technique, so I'll do this briefly. But on CPAs, again, we're gonna match the level of kyphosis of the spine, coming in with the pisiform here, and I'll usually try to palpate C7. Okay, go ahead and lift your head, look up, perfect, come back down. So C6 should disappear with that, C7 should stay. So I'll start here, and again, I am applying a PA force, but I'm gonna match the level. So this is gonna be, add a little bit more of an angle, caudal angle here, and just pressing down. And for this one, I find it easier to stand at the head to give me the better angle. Here, I'm just on the spinous process. And I will move with the level as I go down the spine. Keep going here. I won't bore everyone, but again, as we come all the way down, I've ended up kind of coming this way and having more of a cranial angle with the PA. You can also do this by doing bilateral transverse processes. He's got a pretty stiff thoracic spine, so I don't know that I would be able to get a true like grade 3, grade 4 with bilateral thumb, and it would probably hurt me. So I'll do pisiforms, almost like I'm gonna do a pistol manipulation, and just go here this way on him. This is more of a grade 3. My best mentor always told me that if you have a runny nose, it should hit the segment that you're working on, and so that's kind of where I stay. The only problem with this way is that it's hard to be exactly sure that you're on the same 2 levels without really like diving in and looking. So we may be getting a little bit of rotation with this one inadvertently, just by not being exactly in line, rather than just pure extension like we do with the CPAs. And then of course we can do UPAs on the transverse process, unilaterally, promoting extension on that side, as well as side bending and rotation. There is a lot of mixed research out there on force coupling, but what we would believe is that being on, say we're doing a right-sided UPA, would promote right side bending and potentially left rotation. Again, that would be from the superior segment versus the inferior, but there's a lot of mixed research out there on the force coupling anyway. So really we're like most of the time just looking for pain provocation, test, treat, retest, and asterisk signs, of course, #fellowship. So, and would do the same thing as I did with the CPAs, matching the level of the spine there with my force, and then we've talked a lot about grades, so I've already gone over, so I won't do that, but thank you for watching, and that is all.